My name is Mary Headley Brown. Ever since I was a teenager, I've had terrible heartburn. I didn't know that my lining was changing. When I was diagnosed with Barrett's esophagus, my doctor had to bring me in every 3 to 6 months to check it. And then when it became high dysplasia, he referred me to Dr. Dhaliwal.
I'm Dr. Harry Dhaliwal. I'm one of the therapeutic gastroenterologists here at the Ottawa Hospital. When I did the initial diagnostic endoscopy to evaluate the Barrett's mucosa, Mary had 2 nodules within that area. When those nodules were removed, they both contained cancer. With RFA and ablative therapy, we're able to treat patients early. This prevents a progression to high-grade dysplasia, which was previously treated with esophagectomy.
So he started every 3 months. He'd remove the Barrett's from the esophagus. A few years after, he was recommending me to have the ablation because we now had one of those machines in Ottawa.
At the Ottawa Hospital, we had a fairly comprehensive program with regards to Barrett's surveillance. However, we did not have access to the RFA technology. After a constructive dialogue with our hospital administration, we were able to achieve that goal of getting that technology brought into the hospital. This has been proven to be not only a safe and efficacious technology, but also one that produces a durable response at treating Barrett's esophagus years out. Mary's case is actually an excellent example of someone who has maintained a very high quality of life by having minimally invasive therapy completed to eradicate her Barrett's esophagus and her early esophageal cancer. She was someone who had had undocumented or undiagnosed Barrett's esophagus for an extended period of time, and she was fortunate enough to be able to have that identified and be followed.
I really feel that patients should be their own best friend. They should call their doctor's office when they think something's wrong. And anybody who has a history, like I had of that, get checked.
Some of the difficulties in identifying patients with Barrett's esophagus are that there's a large percentage of patients who don't actually experience symptoms of acid reflux. They may have undiagnosed Barrett's esophagus and we may not be aware. The patients who do have risk factors and have symptoms of reflux for an extended period of time should be getting surveyed. Even younger patients that have long-standing history of reflux and have Barrett's mucosa, if there is a family history of esophageal cancer or there's a large segment of Barrett's, they should be considered for ablative therapy.
All those years I had heartburn and acid reflux. It never ever occurred to me that it could cause cancer in your esophagus.
60% of patients with acid reflux will have no symptoms of retrosternal burning or some of the symptoms we typically associate with reflux. Thereby, we often miss those patients. So a part of the struggle for us as physicians is being able to screen patients appropriately and selectively bring patients in to test for Barrett's esophagus. If we're able to capture those patients and get that message to the primary caregivers, I think we'd be able to increase our capture rate.
I would tell people, anybody who had been diagnosed with Barrett's, to go with the treatment, get rid of it before it turns to cancer, because it definitely can.
RFA is a proven technology in treating Barrett's mucosa. It is known to be safe, it's very tolerable, and there's a very durable response.
Now I feel much better.